Is that working?
It is online, Charles, for me.
Okay, well, the issue is apparently we've got no sound on YouTube. Callum, give me some good news, please. Pretty please. Is that working? Oh, right, great. Okay. So thank you everyone for your patience and sorry for that delay. So to continue with where we were, we're now moving on to item 28, which is the Wellbeing Board Steering Group, to receive an update on the Wellbeing Board Steering Group. And that's over to Ingrid, I believe.
Thank you, Chair. Got some slides to share with you. This is a brief item which has been brought over from our last meeting, from when we were discussing our health and Wokingham strategy into action. So you will all have been part of that process, and this, I hope, will be not news to anybody. So having approved the Wellbeing Board strategy back now in the autumn of 21, the next step for that was for us to formally agree a new governance structure around that strategy into action. So that's what I'm just going to go into today. So this is just a reminder of our 5 overarching priorities and the Wokingham priorities underneath each of those for our forward-looking strategy, broad-ranging strategy into health and wellbeing for our residents. We have a structure of action groups and partnership boards that will be taking on lead roles to deliver on these priorities and report their action into the Wellbeing Board. You will notice one slight change to this is the health inequalities priorities, which have we are proposing become cross-cutting in this strategy. We did have a health inequalities action group, which is currently on hold. The group themselves asked us to consider the integrated and obviously cross-cutting nature of health inequalities across all of these groups, and that actually the actions and priorities would be best delivered within each of these groups with a definite focus on health inequality for each one of those groups. So this is the structure being proposed. In terms of governance, we have our strategy into action, which is the health and wellbeing boards, primary strategy around health and wellbeing. And what we're suggesting is that this a new group, the steering group, is being set up between the health and wellbeing board and the delivery groups underneath here. So there are 8 delivery groups and this obviously one steering group. So with this structure, I don't think it's new to anyone. So just to give some detail about what we expect that to do. The aim of this steering group will be to provide operational oversight of progress against the action plans identified by each of the action groups, and to identify any either exception reporting or escalation to a wellbeing board, a public wellbeing board meeting. And that might include performance and or risks, clearly. What we're proposing is that the steering group meet bi-monthly, every other month, in place of what is currently an informal wellbeing board. So obviously this one is a formal wellbeing board, so the first steering group we propose would be in March 22. And at each of these steering group meetings, there would be 4 of our partnership groups would report against their defined action plan. It would enable the steering group to have scrutiny of performance, quality and progress, and obviously to identify areas to escalate, but obviously also areas of best practice to share. So it's really a sort of operational board looking at the delivery of our strategy into action. In addition, we would ask each of the action groups to take an annual review to the Wellbeing Board, but also that steering group will have oversight of the updates of the action plans, which will be done on an annual basis. So I'm happy to take questions on that. But in terms of that, the members of the steering group, we what has been decided or is being proposed is that it would be the same as our Wellbeing Board, so or a nominated representative. So all of those here on the board, or indeed they can choose someone to attend on their behalf. And we're suggesting, in addition, a PCN director be approached to sit on this steering group, a representative from health providers and another service provider representative, as well as a secondary head teacher for matters arising to children, young people, families. So that is all I was going to say about that, but happy to answer any questions that arise.
Thank you, Ingrid. I'll now ask for any questions. I think Katie's got a question.
Hi, Ingrid. Thank you so much for that presentation. It's very clear here, actually, the approach that you're taking. I think it's very much welcome. Can I just double check the groups that you had listed, the actual chairs or the overarching programme leads? Are they going to be members of the actual strategy to action group? How are we catching all in that group as well, or?
No, so then they won't be members of the steering group, but they will be coming to bi-monthly to do their reporting. So it will be the chairs from each of those groups or a nominated kind of lead on the action that will come to report to the steering group, but they won't be themselves members of the steering group. There is some discussion about the operational bit underneath the steering group and whether there needs to be an operational group with those chairs in terms of interconnection and discussion around their delivery, but they will be coming to the steering group but not members of it.
Yeah, I understand that. That's really clear. Are we expecting therefore those those programme boards to actually programme groups to provide every other monthly updates?
Yes, so it will be quarterly, because 4 will come at one. It will be every other month, and 4 will come to each steering group. So it will be quarterly reporting.
Thank you.
I believe there's a question from Helen as well, please.
Thank you. And Ingrid, that was very, very clear and helpful. So thank you for that. I've got a question about head teacher representation and an offer of support there. We've now got the Borough Education Partnership in place and it's meeting next week. Would it be helpful if I seek a representative from that?
Yes, please. That would be fabulous, Helen. Thank you.
Lovely. Happy to help. Thank you.
I had a question, Ingrid, actually, which was when do we need to be finalising the membership of the steering group?
So I think that we will aim to meet for the first time as a steering group in March, but we will hope to have everyone in place by then. But if we have some members that need to join in May, then that we will give ourselves till May to get that finalised.
Thank you. Katie has a question.
Just backing on from what Helen was saying, do you need help with identifying a PCN clinical director as such, as well as also names from the Royal Berks or Berkshire Healthcare Trust?
So I think, thank you, Katie. I think potentially my thought was to take that to the whip and to offer the position or have that discussion with the PCN directors across the board. So we might take that offline, but yes, all help welcome. Thank you.
And what about the Royal Berks and Berkshire Healthcare Trust?
Yeah, so I know Tracy's online, so we can absolutely have that discussion perhaps and see who might be best placed to join us. But yes, your input on that gratefully received. Thank you.
Any other questions or comments on that? No? Well, if I can ask basically that the report is noted, basically, and thank you, Ingrid.
Thank you.
And then we will move on. We're leaving item 29 for the moment until, oh, no, we're not leaving item 29. I lost track there. We're doing item 29, and that's Lewis or Martin, please.
Good evening. That's me. Up from the top. Good evening. Just to give you an update on our BCF annual plan. Those of you that are familiar with the BCF, we have a bit of a strange planning arrangement, and often we don't tend to get our actual plans through until partway through the year. This year we were presented with our templates to present our plans back to NHS England in September, with us having to submit our final version to NHSE on the 16th of November. This is essentially a formalisation of the plan and the budget, which was agreed by you guys earlier on in the year, and which was created with all of our partners in our Wokingham Integrated Partnership earlier on in the year. The annual return itself, as we do everything in our partnership, was developed all together with colleagues from the CCG, BHFT, Royal Berks and Western Berkshire local authorities, as well as the planning obviously was done with our other partners, including the voluntary sector earlier on in the year. Overviews of these plans were shared with our delivery group and also with the leadership board, so operational and senior managers. We were able to submit a draft, which was done in timely fashion, feedback, secondary draft, and we submitted on time as required. Subsequent to the submission of this, we have this presentation. We have had it accepted by NHS England as good. So to get into the plan itself, the finance section, as you can see, lots of fantastic numbers. All of our minimal contributions were met by all parties. All of our national conditions have been met, and essentially the budget was the one which was agreed earlier in the year. So what did that budget actually buy us? So as you can see here, there's a laundry list of services, and this isn't all of them. But just to sort of say that they support prevention, admission avoidance and discharge from hospital. And as you can see from the list, there's the budget supports members of the voluntary the organisations from the voluntary sector, from Berkshire Health Foundation Trust, as well as the council, to do those fantastic things. I have a suite of some new targets this year, which is a positive from my perspective. The first one off the docket is emission avoidance. So this is a change from the traditional non-electives or NELs, depending on where you're from. And then the second one here is around length of stay, which has replaced DTOC or delayed transfers of care. Both of these topics of targets have historically, or these metrics historically, have been discussed and nuanced. So the unplanned hospitalisation for chronic ambulatory care sensitive conditions is a list of 9 conditions, and it really aims to get to the nub of the work that's being done via BCF to ensure that we are supporting people who wouldn't necessarily need to go to hospital to keep them in the community healthy and safe. Secondary, around the length of stay, that focuses on 2 elements. One, which is the discharge of moving people out of hospital in a good fashion, in a timely fashion, but also its length of stay. So if people are well conditioned, they will stay in hospital for less time. All of the targets have been exceptionally challenging. They are achievable, but they are very challenging. NHSE are keen to keep the levels of performance from last year, which were very high. During the pandemic, unplanned hospitalisations and length of stay were generally low. And as such, they've pressed to ensure that this keeps going. As guidance was made only available very late, we only have planned returns for Q3 and Q4. However, because it was then subsequently so very late with responding to the plans, we're only going to have to report on Q4 or end of year. We have a few more targets here, and these are the social care, or more aimed at social care. They're orientated there. Whilst they are different, they again have the same ethos as previous Better Care Fund planning stuff. So around percentage of people that need to return home, again, it's really good that we increase our percentage of people who are returning back to their own homes. With regards to residential admissions, again, it's the same thing, looking to keep residential admissions low so that we're able to keep people in their own homes for as long as possible, which is where people want to be. And then also a reablement piece around where you're still at home for 91 days. Some of these targets were set across the West of Berkshire because obviously we share providers in BHFT and our hospital, so that's really good. And yeah, our performance around long-term placements was very good, as there was generally a desire for people not to move into care homes during COVID. And to reflect that, this year we have dropped our target from roughly 12 a month to just under 10 or fewer, which is very good. All of these are monitored via our dashboard for the leadership board and via the delivery group. So we're ensuring that we are keeping on top of those metrics as best we can, and where we are finding things being challenging, we're able to address our performance with our colleagues to see if we can find new, innovative and ongoing solutions to our issues. And then the last piece of the plan was around a narrative. So we had these various different sections, as you can see, to complete as we move through. It was very well accepted. It was a relatively easy exercise for us in Wokingham, as we'd already completed our plan prior in the year. So essentially, it's looking good. There is a piece where we need to involve our colleagues from housing more into the discharge planning process. And it's something that we're going to be exploring in the coming project year, the coming financial year, to ensure that we are covering off all of our aspects of our work. And that's me done.
Thank you, Lewis. Can I ask for any questions or comments to Lewis, please? I've got a question from David.
Thank you for that, Lewis. I'm always a little bit worried about length of stay in hospital, because I know, and this is a personal thing, I was discharged after 3 days. 2 days later, I was back in and was there for another 4 days. And so, you know, it's the cat. You know, sometimes it's good, and sometimes you're pushed too early. And again, even 10, 12 years ago, they were doing about how not staying in hospital too long and so on. How can you make sure that you are discharging the right people at the right time, because that's what's important?
Yeah, so the two targets together, so when you layer one on top of the other, we have our length of stay targets around 14 and 21 days to ensure that we don't have people becoming what is referred to as stranded or super stranded in hospital. But then you layer on top of that our 91-day target. So that's where people have gone home, and then we're monitoring the percentage of people who are still at home 91 days later. Obviously, with the percentage of that, we want that to be as high as possible. So there's a target associated with that, and our reablement services do a jolly good job of supporting those guys to support people to stay independent in the community.
I just saw the 91 days is over 65.
Yes.
I'm still not that yet, and certainly I won't.
No, not suggesting you were, sir. Not suggesting you were. But the better care fund.
That's the problem. It can be younger people who seem fitter,
yes,
but still have things to work through after an operation or something.
The better care fund is aimed majoritively at those that are supporting those people that are older people. So that's why the targets are associated with the 65 plus. It's a very good point, very well made. And we do continue to support our hospital with our OTs and health liaison team to ensure that we do get people out at the right time and get the best outcomes. I have our colleagues who are operational in the adult social care team every week have several discussions with our colleagues from RBH to make sure that we're getting discharge right for the people in the borough.
Thank you. I'm going to go next to Katie, then Martin, Debbie.
Yeah, just the councillor's question, just as Lewis was saying, there is weekly, meetings every 2 or 3 meetings each week, which review those individuals that are classed as medically fit for discharge. These are individuals, there's no age parameter in those. These are anybody in the rule box. It's actively talked about as a multidisciplinary team to make sure actually they're making the right decisions to make sure that those people are safely discharged and are not readmitted. It's also worth to note that actually the UEC board actively monitor readmission rates as well. So they're constantly learning on if there are issues and then responding to those and flexing the pathways. So just to note that and to support Lewis in that response. The second thing I'd want the board to note is the hard work that Lewis has been put in to design the actual plan at very, very short notice. It's a big thank you to Lewis and the wider WIP team in order to respond incredibly quickly in a very short time period in that planning guidance. The third thing I'd want to note is actually at the moment where we got the actual BCF planning guidance come out quite late, it did make it very, very clear that actually what we should be supporting at the moment is how we're going to design our plans for 2022, 2023. And with that, there needs to be an eye on how we're supporting COVID recovery. So it's fair to say the Health and Wellbeing Board should note that actually there are meetings afoot about looking at how we take the asks that has been put to us to make sure we design our plans in 2023 with that COVID eye lens in the forefront. It's worth noting that, Chair. So just wanted to put that point across.
Thank you, Katie. I'll now go to Martin and then to Debbie.
Yeah, I was just going to add on around the sort of readmissions. So RBH do regularly check their readmission rates to see, they call them like failed discharges. But also just want to say that our social work teams, whenever they are supporting a discharge and then the person goes back in again, they actually log that into RBH as like a complaint. So it means therefore then RBH then actually review each patient to try and see what the learning is, to try to make sure then that we have as few readmissions, like the example said there, as possible. So our teams also are part of monitoring that failed discharge rate.
Thank you, Martin. Debbie.
Yeah, and I agree with what David's got to say about, you know, people going home too early. So the kind of the sentence at the moment for the Royal Berks is fit to reside, which is actually a national framework, basically stating whether patients can actually stay in hospital, and if they are fit to reside in hospital, they can stay, and if they're not, then we really need to be working hard to getting them out. James Kent is also doing some work on the early discharge. As you're aware, in COVID, there was a real push from the national team to try and get people out as quickly as possible. But that kind of wasn't always possible because there weren't enough carers in the community. And I think what Lewis's team been working with local care providers, is they're also aware of this as well, is that when people come out, perhaps even 1 or 2 days earlier, they may need double up care, which is difficult to find, but actually just keeping them in 1 or 2 days longer, which is against national guidance, means we can actually reduce the care that they actually need. So James is doing that overview piece to just basically see, even though the national team are requiring you know, standards, whether locally we need to be looking at this differently, so that we can get the best for our patients, but also ensure that the care they need is actually is available.
Thank you, Debbie. Any further questions or comments for Lewis on this item? No. Okay. Thank you very much, Lewis. Basically,
thank you.
That's great. Thank you. So, moving on to, we're holding item 30 because I believe Dr. Kent is joining us at 6 o'clock. So we'll move on to item 31 now, the refresh of the Berkshire West Local Transformation Plan, improving the response to children and young people's emotional well-being and mental health. And I believe that's Nikki Cartwright. Nikki, over to you.
Thank you very much, Chair. Could I just check, have people had the slides circulated to them? No. So I'll share my screen because I've got a short presentation. So I'm assuming that everyone has read the front sheet that was circulated, and I'll just do a brief overview.
That's fine. Please proceed.
Okay, Chair. Thank you. Ooh, it's a bit, keep whizzing in and out. Here we go. So this is our local transformation plan for children and young people's mental health and emotional well-being. As you can see, it was actually September last year when we published the refresh. The document builds on the 2019 plan that some people may remember, and provides an update on what has been achieved so far. It looks at the local needs, trends and the voice of children, young people and their parents and carers. It talks about our commitment to undertake further work that's required and the resources that are required to support that. So I thought that I would not focus on the past and what's been achieved. I thought it would be helpful if we talked about the future and the work that we're going to be doing going forward. Just as a reminder, our goal overall is to reduce the number of children, young people and their families whose needs escalate and require specialist intervention, a crisis response or an inpatient admission. And the transformation plan has been refreshed in line with the requirements of the NHS's 10-year long-term plan. Successful delivery of that plan, so that means outcomes for children and young people and their parents and carers, would mean that good emotional health and well-being is promoted from the earliest age and poor emotional health is prevented wherever possible. That children, young people and their families in our communities are emotionally resilient. That more children and young people with both an emerging mental health need and a diagnosable mental health condition are able to access evidence-based services in a range of settings. And that fewer children and young people will escalate into crisis because we're doing that prevention work. But for those that do, then good quality care will be available quickly and will be delivered in a safe space, enabling them to recover as quickly as possible. Sorry, I've just lost my slide. So our refreshed priorities, and there's a lot of detail in the paper on the work that supports these, but that's about building a formal delivery partnership arrangement. So making sure that the governance is really tight and is formalised and works across the 3 local authorities and the CCG and other providers. That we have a single access and decision-making arrangement that will work across that delivery partnership. So again, trying to streamline our decision-making, make it as swift as possible. Tackle our waiting times in both specialist and core CAMs. And we've heard a lot about the increase in demand during COVID and what that has meant when it's been translated into waiting times. So a big focus on that. Meeting the eating disorder waiting times in response to referrals. Again, through COVID, we saw an increase in eating disorders, but also an increase in disordered eating. That has put pressure on services. And then mobilising a community home treatment offer that would work 24/7 and provides access and standards for crisis cases. And then finally, the last 4 priorities are mobilising 2 further mental health support teams. Those are teams that work into schools. We've got a number of them already across our health and social care system. So there'll be 2 more of those, meeting the COVID-19 surge demand as it arises, addressing gaps in access and service offer due to inequalities, and finally strengthening our adolescent to young adulthood offer. So that's for young people who are aged 16 to 25. There's a number of project updates, which I probably won't go through because I think it might be helpful to have to open up to questions if that's acceptable to you, Chair.
Nikki, thank you. I was going to ask, basically, the slides are too small to read in the chamber on the monitor.
So sorry.
No, not at all, not at all. You're not to know how big they come through here. But I was going to ask if you could forward them to us, please.
I will do, yes.
If you'd be happy to take any further questions on email, should they come up when people have had the opportunity to see them. Yeah. And before I go any further, could I ask if there are any questions in the chamber or online? Matt, one for you.
Hi, Nikki.
Hi, Matt.
It's a question for you and Ingrid. In that we talked about our strategy into action wellbeing plan. This is one of the priorities in that. There's an action plan around this priority and some governance around that. How is the action plan from this and that governance working together? Or is that a conversation that needs to happen?
I think it's a conversation that needs to happen, and helpful that you've raised it.
Okay, good. We'll make that happen.
Offline.
Yeah, of course. Yeah.
I can see there's a question online, but I can't see who it's from. So, Helen.
Oh, thank you. Yes, Nikki, thank you so much. That was a really helpful overview. and the Children and Young People's Partnership would be delighted to receive this presentation if it hasn't already been there. I suppose I'm welcoming the breadth and the depth of the work that's being undertaken. And I suppose the question I've got is really about the impact of COVID, and you referenced it. We are seeing really increasing demands around children who have experienced real difficulty through the pandemic. Are you assured that this transformation plan will have sufficient coverage? I suppose we're in the early days of recovery. So just your views on that. Thank you.
I think we are, Helen. I mean, we did put in place, along with the local authorities, a number of increased capacity around COOF and BEAT and sort of eating disorders. We have an eating disorders recovery plan, which does address the impact of COVID. We've got a number of other pieces of work that we're doing to look at that. And I think it's just we need to just constantly keep our eye on it, because I think every service is feeling that pressure. And, you know, I think if we work together, that's the best way of tackling it. And I'd be really delighted to share it with the partnership. I think that'd be great.
Wonderful. Thank you.
Thanks, Helen.
Any other questions or comments for Nikki? Okay, I think that's silent. So, Nikki, I'd like to say thank you very much for coming tonight, basically.
Thank you.
Yes, thank you. Right, the next item, item 32, is the ICP Unified Executive. I am guessing, correct me if I'm wrong, that it's Katie to present this?
I think it'd probably be myself and Matt to present this going forward. I wasn't, the ICP executive met today. I'm not too sure what report you wanted to do, Matt.
I mean, if it helps with your voice as well, I could do
sure.
I could do the presentation. So it did meet today, but this is the chair report from December. So because we've had a number of boards postponed, this is kind of carried over. And we do this every time. So this is an update from the Integrated Care Partnership Executive that works across Berkshire West. Katie's part of that. I'm part of that. Susan goes to that. So this is about drawing those linkages between the work streams. So I won't go through each of the sections. I don't think some of them are a bit dated now, but I'll draw people's attention, I think, to the ICP priorities for 22-23, because there's been quite a bit of work gone on there to align those priorities across Berkshire West with priorities in our strategy into action plan and some involvement with the WIP there. So we've got some nice alignment of priorities in there, and as you can see, they're listed out there. And I think you would have seen that in the presentations tonight and in some of the priorities that we've talked about before. So there's some good alignment there, which is really good because it means everyone's pulling in the right direction for the right priorities that we set for the borough, rather than lots of people working on separate things. So happy to take questions about any of that, but I think that's what I want to say. Is that okay, Katie?
Okay. Any questions for Matt or Katie on this item? Okay, I think that's that. So basically, we're then on to, thank you to Matt, thank you to Katie. We're then on to item 33, which is the forward programme, which is page 59 of the agenda. I'm not going to read this out. I think everyone's had the agenda basically, and just any comments or questions on that? No. Okay, so I believe the only item remaining is item 30, which is developing our integrated care system discussion. We're obviously waiting for Dr. Kent, basically, who I believe is joining us at 6 o'clock. So I'd suggest a short adjournment till 6 o'clock, basically, and unless anybody knows different, and then we can take things from there. Thank you.
I believe you've got the slides in your pack, so I'll just say a few words to them and then more than happy to get into the discussion conversation. So first of all, to highlight, we are still very early in conversations around the development of the integrated care system, and wanting to seek the input of all of our partners in that. So as the pack shows you, I'm going to cover quickly the context we're in, the purpose, key aspects of the ICS, and then where we are in terms of the development and thoughts around some of our governance. And as you will all be aware, this is based on a bill that is currently going through Parliament, so everything is still subject to legislation, and during the various stages we know amendments are being put down, so we don't know what the final position of the bill will be. When this was written for you back in December, the aim was obviously to have statutory status from the 1st of April 2022. That's been put back to the 1st of July 2022. But again, to reiterate, we see that as at the starting point of a new organisation that will need, and system that will need to evolve over time, and that evolution absolutely needs to occur with our system partners. And also as part of this context, this has been built on quite a few years' discussion from the publication of the NHS long-term plan, and that commitment to needing to work more in collaboration and with integrated services. So NHS England had been asked to put forward proposals which are are being acted upon in the draft legislation, and that goes back to the 4 goals of the ICS, which were first highlighted in the NHS long-term plan, about improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access, enhancing productivity and value for money, and helping the NHS support broader social and economic development, all of which are the kinds of things that you in health and wellbeing boards concentrate on. So what's being changed is how we organise ourselves in the NHS to deliver this. As is the NHS's way, this has generated a whole set of new 3-letter acronyms. So the integrated care system is the whole system across Buckinghamshire, Oxfordshire and Berkshire West, including our local authority partners, provider trusts, health watches, practices and the PCN, and it's a partnership. Within that, we jointly with our local authority partners set up a joint committee that is an integrated care partnership. The NHS statutory body within the whole system will be the Integrated Care Board, which has a unitary board. And then the other aspect that I want to talk about today is how we build on the local working through place-based partnerships. Again, when this was written, it said from April 2022, but from July 2022, the CCGs will no longer exist and all our CCG staff will transfer into the Integrated Care Board. I'm not going to talk about the slide in your pack that's about changes to terminology, but I think get into the area about system and place. Within our geographical area, we are a system made of 3 NHS terminology places. We don't have a single focal point that some of our other South East ICS colleagues do. So we're not a single county and we don't have a single acute trust within our boundaries. We have in NHS terms around our acute hospitals 3 strong and distinct places. Most care delivery will still be managed and delivered, or will be managed at place. So we see that the overall system orchestrates the strategy and delegation, but place manages that delivery. So things like pool budgets, delivery on urgent and emergency care, long-term conditions, integrated care, and also how smaller geographies work. So our practices, our primary care networks, our relationships with the unitary authorities in Berkshire West, district council areas in Oxfordshire, about how do we focus and work together to reduce inequalities. And then also how our providers work together above place, delivering services across the whole area. And we want to work together with all our partners to evolve that system and place discussion about where it adds most value, that the integration and deliveries at place with our local partners, and where it adds value for us to work at the Buckinghamshire, Oxfordshire and Berkshire West system level. And so in each of our 3 areas, there is already the beginnings of how that place works. And I noticed on your agenda, I think it's later on your agenda, but you might have thought it. But so the Unified Executive in Berkshire West already brings together parties to deliver on integrated care. So that can evolve into being the place-based partnership for the Integrated Care Board, can be a subcommittee of the Integrated Care Board, which means we're enabled to delegate a lot of authority and autonomy into that committee, and it will take many of the decisions that are currently in the CCGs today. Also, the kind of work that you've been doing through the Unified Exec around the driving changes to deliver integrated care across those pathways. And then within the ICB, there will be staff, as I said earlier, transferred from the CCGs who will support those place-based partnerships. Then there's a very high-level overview slide that shows the parallels between place working and system working. So health and wellbeing boards in the places, having a link into the integrated care partnership at system level, and then the place-based partnerships having a link into the integrated care board. Again, in place, we would have scrutiny through the established scrutiny committees, and if appropriate, the Bob Scrutiny Committee could review us. Then the final slide, the draft legislation and guidance from NHS England sets out a proposed minimum board membership for the Integrated Care Board, which has a chair, and our chair designate has been appointed as in place, Javed Khan, a minimum of 2 independent non-executive directors, which we're in the process of recruiting those. The chief executive, and James Kent has been confirmed as our chief executive designate. We then have what are called partner members who come with sector expertise. They're not representatives of their sector, but to bring that perspective into the discussion of the Integrated Care Board. 1 from local authorities, and that's local authorities who deliver social care. So the 5 within, 1 from the 5 within our area, 1 from primary care, and 1 from NHS providers. And then 3 executive positions that are expected to be members of the board: finance director, medical director, and the nursing director. Then I think also in the pack, there's what we call an appendix, which just has some more detail on some of the terminology and the bits of the structure. But if I leave it there, and then happy to take questions, have a discussion about this.
Thank you. Basically, right, can I take any questions, please, either from the room or online? Catherine, can I ask, are you happy to answer questions on behalf of James Kent? Do you know if James is coming, or?
I thought James was coming. I'm happy to answer those I can, and those I can't, I will take away and we'll get back to you. But James and I have been working very closely on this.
Okay. Well, perhaps I'll go to Helen first, if that's okay, basically online.
Thank you. Catherine, thank you. That was a really helpful overview presentation, which I welcome. I should introduce myself. I'm an Interim Director of Children's Services in Wokingham. I'm going to come at this from an angle around children and young people's needs. I know that in some parts of the country, separate boards are being established to ensure that children and young people's needs and issues are really central to the broadening of this agenda. I'm just wondering if any consideration has been given to a children's board as part of these arrangements. Thank you.
Thank you, Helen. So I suppose I should also have said this is obviously only showing a very small part of the structure, and a focus on the Integrated Care Board and the partnership. Through our discussions with place and priorities in place, we want to discuss how they might want to arrange themselves. So there might be separate children's groupings boards at place, and also for the ICB, we're thinking about the sort of work programmes and the way we will need to structure ourselves across. So those are not established, not agreed, not set in stone. It's about taking parts of the structure at each point, and fundamental. We need to establish a safe organisation that can effectively work from the 1st of July, and the statutory organisation needs its board and some of the supporting infrastructure in place. But those other conversations are the reasons we're coming out to talk to health and wellbeing boards and other partners about how do we best organise ourselves to deliver against our joint aims and priorities.
Okay, thank you.
I'll go to Tracy next and then to Bill online.
Thank you, Chair, and thank you, Catherine. It was a really helpful presentation. 2 points to my question, if I may, please. The first one is, obviously throughout this is all about partnerships, and all of us have got a role to play in that. And what isn't coming clear at the moment, it seems very dominated by the NHS, as we'd probably expect at this stage. But as it settles, do you see this as a partnership of equals? And is that the ethos in which it is being created? That would be my first point or question. And the second is obviously with the long-term plan and how that is going to be reignited, and alongside recovery with health inequalities at the core as we go forward. What do you see as the position of prevention, particularly primary, secondary and tertiary prevention in this, and the influence and role of public health in that?
A lot in there, Tracy. So thank you for this. So absolutely, we see the integrated care system and all the elements of it as a partnership, and I suppose it's about slightly differentiating the broader partnership and the setting of that strategy, agreement of that strategy, and then the delivery vehicles. We can't get away from the fact that the Integrated Care Board is an NHS statutory body. But it is being set up in a different way in terms of how that board structure will work. So with the partner members on it, it will broaden the discussion and perspective. Whether or not you call that an equal partnership in terms of the board structure itself, but it's a statutory body that's got to deliver its statutory duties, reporting to NHS England. Absolutely, the Integrated Care Partnership is where we, the NHS, are required to set that up in partnership with our local authority colleagues, and it to be a joint committee. It won't be a joint committee that we all agree to unless it's set up in true partnership to set that overarching strategy. But I think also going back to the place discussions, those focus on prevention that you talked about, reducing health inequalities, is where we need to really strengthen our joint working in places with our local authority partners to drive and deliver on the things that need it. So I think prevention will run through everything we do, but also going back to the answer I gave to Helen, we probably need to think about what are the ways of working, groups, boards we need to set up to ensure that focus is on it. So say I've only shown you a tiny bit of the governance structure that we've got to think about, and if we take the core objectives of the Integrated Care Board, one of which is that reduction in health inequalities, we would want in partnership to think about how does that mean we need to work? How do we ensure it is top of mind in everything that we do, and how do we then organise ourselves to ensure that that can be focused on and delivered. Does that make sense?
Yeah, and I should have introduced myself correctly. I'm the Director of Public Health, hence my question.
Yeah, I think I met you at one of the other health and wellbeing boards.
Indeed. Thank you very much.
Thank you. Now it's to Phil, then to David in the chamber here.
Thank you, Chair. Hello, Catherine. I do hope you will forgive me, but would you be able to tell me what your role is? Because it would be helpful to know how you were approaching this.
Oh yeah, I'm very sorry. So I'm currently one of the clinical commissioning group directors in Oxfordshire, and I lead on governance and comms and engagement. But I'm also been working with James to lead the development of governance in line with the guidance for the Integrated Care Board.
Thank you so much. That's really helpful. So you know who I am. My name is Phil Cunnington. I'm the Deputy Executive for Health, Wellbeing and Adult Services in Wokingham. I was looking at the structure, and one of the things that struck me is that the ICB, whilst you say unusually, it's not just got one single focal point, it's only got one local authority representative. You've got 3 places potentially, or which doesn't necessarily represent the number of local authorities that are involved. So how will Wokingham residents have their voices be heard in that structure when it's so many layers potentially away from the ICB?
So this one, again, to reiterate, those partner members are not representatives of their sectors. They come with expertise. So it goes back to our the bit about the importance of place and how does place operate within it, because so we will have a lot of freedom to be able to delegate resource and authority to place, so to Berkshire West, and work with Berkshire West and the 3 local authorities in Berkshire West to say, how do you want to organise to deliver to ensure that the needs of the different populations of the different local authorities are heard and their needs are met.
Thank you.
That balance, but in terms of the board membership, and it is a conversation that will need to be ongoing. We've also trying to maintain balanced membership between partner members, executives, non-executives, sectors, geographies, and so it is and not get too large. So we need to keep having that conversation.
Okay, thank you. Obviously, you've recognised some concern in the question from me, yeah. As someone who's had to be elected to speak on behalf of Wokingham residents. I know that you don't want to get too much in detail because there's so much to still yet be understood, but I want to give you an example and see if you can unpick just how that might happen. Just prior to your presentation, we had a presentation from on the Better Care Fund and run by the Integrated Partnership, and the success of that, and the fact that, for example, unlike many other places, it's not just about discharge to assess, but it's so many other elements which are specifically local and in incorporating our local voluntary and care sector. With the BCF, how can you commit that there would be no change to Wokingham's BCF governance? And so would you be able to renew a commitment from the ICS to support the integration partnership that we have built into such a strong board within Wokingham?
So I think one of our absolute principles is Better Care Fund current pool budgets. We want to maintain to be governed and run locally as they are now, and in sort of the next layer of detail and discussion about place, that's what we would come out with. So we don't want to suck pooled budgets or Better Care Fund arrangements up to a system level when they are about our partnerships at place and with our local authority partners. So I think I'm saying yes.
That's really good. Although from my hat, obviously, I see that through the prism of an extra layer of 3 local authorities who are competing to try and actually see how that's utilised. But thank you very much for your answer. That's at least helpful in that run. Thanks, Chair.
Thank you, Phil. Over to David Hare in the chamber.
Thank you, Chair. Phil's talked a lot about what I want to talk about, because Wokingham seems to be almost forgotten, because place is West Berkshire and then you just get bigger, and it seems that it's not focusing on the local. And I was just looking at the purpose of the ICS and just improve the outcomes. The outcomes in Wokingham would be different from Reading and different from West Berks, but it's one place. And I still find it, you explained a bit to Phil, but I still find it quite hard, in tackling inequalities. Well, the inequalities in Reading are certainly very different to the inequalities in Wokingham and so on. How will that be worked out, or will we still be working with our health and wellbeing boards and so on to work those out? But then the whole ICS, it won't relate to it. So I'm still a bit confused.
I'm sorry. So yes, we'll still be working with local health and wellbeing boards.
David, your microphone.
Oh, sorry.
Thank you. And I suppose I should reflect in the other 2 parts. So Oxfordshire and Buckinghamshire would equally say they've got very different needs in different parts of the geography. So for us, it's about what we do at what geographical scale, and there is much that we would need to do in Berkshire West that is working with the local authority, so at the scale of the Health and Wellbeing Board, that looks at the specific needs of the population in Wokingham and what are the gaps and the things needed to do to address that. Some of what we would expect the support from the overall system to have given is to have shown us that relative need and the needs and the gaps and the inequalities for our different geographies, but then there will be different solutions to those different things in the different places. And as I say, I really have only shown you a tiny bit of what we're doing, and the next time we come around we would want to be talking about how does the place in the NHS terms that is Berkshire West work, and how does it work with the 3 constituent local authorities and the health and wellbeing boards? And you already do some of that, and we need to build on what works well here, in that you have 3 health and wellbeing boards, wellbeing strategy, but a single unified exec that brings all the partners together, and we would want to continue to work with you to say what's best done in each of those areas, so that it absolutely does address the local needs. But say, having spent my recent bit of my career in Oxfordshire, I would have exactly the same conversation in different district council areas, that the needs in Oxford City and Banbury are not the same as the needs in other parts of the county, and we've got to work at the appropriate geographical level to address those needs. So it's not all at Bob and it level, and it is not all at what we in the NHS call place. It will be with you, our local authority partners, it will be with individual practices, it will be with primary care networks.
Thank you, David. I've got Nick Fellows to ask a question online.
Yes, thanks, Giles. Thanks, Kathleen. I'm talking from the voluntary sector in Wokingham, and I recognise the NHS is a huge institution, but it seems to me that the whole structure of this plan is very institutionalised. And not a dissimilar question from the last 2 really, but there are layer upon layer upon layer upon layer of boards and committees and whatever. I just wonder how the voluntary sector, which I think has shown it can provide fantastic value over the last couple of years for not very much money, how the voluntary sector can get more integrated into the planning and have its voice heard, really, and also, bring to bear what it has to offer.
yeah, so again, if I go back to the, this is only showing, I know it comes over as layers and layers, but showing part, and it is a bit of an overemphasis on the governance of the new organisation and the new system. In terms of the voluntary sector, we would expect broad voluntary sector input to the integrated care partnership, which is a committee, but also in terms of things like so one of the other areas I'm working on is our approach to communication and engagement and involvement, and how we work with our partners, voluntary sector, patients and the public in our work, and how we embed it in what we do. So to me, that's the way I would want to turn it round. We need to hear the voice of our voluntary sector partners, along with everyone else that's highlighting issues, areas they could help, areas they could address. And if there's an issue that we're working on, we need to involve the voluntary sector. So we've had very early discussions in terms of development of that engagement, and I'm actually doing a workshop session with the Voluntary and Community Alliance next week to again start to have those conversations about, absolutely the voluntary sector adds value. Where, how do we best work with you? How do we enable you to work with us in something that doesn't look like it's bureaucratic layers and layers of things? And it's bouncing again. So from previous experience, some work we did on mental health in Oxfordshire, we absolutely had the key voluntary sector provider organisations working alongside us and the NHS partner in terms of designing and patients and their carers, designing and delivering the services that met the needs of that group of patients. So I would absolutely endorse the role, and I know we need to change the way that we work to enable that to happen more effectively than it currently does.
Okay, thank you very much.
Catherine, I had a couple of questions myself, if I may. Basically, which is picking up, without meaning to be a bore, but picking up the Berkshire West point, basically, because I know what you said about Oxford, basically, and I understand that, but picking up the specific way it masquerades itself on the ground here, we've had a local issue with a GP practice here, which I'm not going to bother you with the technicalities, but the comment that came back to me, basically, from the second hand, I will say, but via basically from the CCG, was Wokingham is complaining about this issue, but generally GP practices in Reading are far worse than ones in Wokingham, and Wokingham ones are good, but we never hear any complaints from Reading. Now, myself and the other councillors in this room basically are put here by the residents to represent the concerns of people in Wokingham. What's happening in Reading, while I'm sure it's relevant to the CCG, is not really of much interest to us. So our concern basically is that rather than levelling down basically or producing a lot of mediocre, basically that when we raise issues in Wokingham, there's a focus on getting these Wokingham issues resolved and solved. And my question is basically, you've touched upon how it relates in Oxford, but the structures there are slightly different. It's just how, to raise the concern of how Bob would deal with that. Basically, or how those kind of things would be dealt with, because the concern is with the director of place in West Berkshire, we're still going to have the same issue. The second question was, this is a very, very big change, and I could see that a lot of effort has gone into planning this, basically. But with any change, no matter how well it's planned, something is not going to work as it should do, or is going to be missed in implementation. With the best will in the world, none of us are perfect, and that is going to happen. So I wanted to ask what the commitment was from ICS members basically to come to this board, following this change being launched, so that feedback could be given, discussions could be had, and constructive discussions could be had to actually rectify the problems and make sure the interests of the people of Wokingham are represented.
So for your first question, I think I will have to take that away, because it is about that operational delivery model, and I would say we're not into that level of the design and structure, but I would confirm I've absolutely heard the question in the way that you've asked it. How do we ensure we are addressing the local issues raised with us without making some of the points you said. In terms of commitment to come back, yes, absolutely. We also accept, establishing a new organisation. We won't get it all right to start with. We want to take on board the comments, but also we'll want to actively review the way in which we set ourselves up and think about how does that need to change. So we are happy to come back to talk to you, and would probably want to come back and talk to you again before we're set up, let alone after we're set up.
Thank you. I'd welcome that, basically. Any further questions, basically, from John?
Hello, Catherine. My name is John Halsall. I'm the leader of Wokingham Borough Council. The integrated care, the NHS says, is about giving people the support they need joined up across local councils, the NHS and other partners. It removes traditional divisions between hospitals and family doctors, between physical and mental health, and between NHS and council services. In the past, these divisions have meant too many people experience disjointed care. So explain to me, how does a board structure a decision-making body which is completely disjointed and remote from residents and the people they're dealing with do that? The structure that you're designing seems to me that you've taken the whole responsibility for the problem on your shoulders. And so when we have a problem with one of our residents or our local care systems, we can say, actually, we've got no authority at all. It's the ICB. Blame them.
Well, I'm sorry if it's come over. It's not meant to have come over like that at all. And I would say, go back to that focus on the integration. Say that the health services bits will be about how we in the NHS, so our GP practices work together and how they work with our provider trust. But then with that, those wider services, the services that you commission and provide, how we work in the local partnerships. So, what makes sense to provide in integrated teams or wrapped around local practices, local communities in the local areas will not be sucked up into the remote integrated care board. It's absolutely the sorts of things that we would be having as the discussions in the local context and with our health and wellbeing boards and with even more local geographies than that.
Nobody within the new setup has done anything to try and convince leaders like me that that's not the case. I'm very, very alarmed at what's happening. We've had a lot of success in trying to bring our voluntary sector and our health sector and our care systems into to working together. And at the moment, nothing allays my fears that this positive momentum we've built up is going to be killed by a remote body which has nothing and no interest in what we're doing. Since this the organisation has been set up, I have had no contact with your chief executive, and it's a real failure in my view that your organisation has not reached out to people like me.
I can only apologise. I mean, the new organisation is not set up. We are currently still 3 clinical commissioning groups. Oh, James, do you want to?
Good evening, and apologies that I'm late joining. I've had a meeting that was very hard to sort of I was chairing and can get out of, so apologies for being late. Catherine, carry on.
Good evening, James. Basically, I don't know if you heard John's question, but I think Catherine was about to say, correct me if I'm wrong, Catherine, that she would ask you to respond another time to it.
Yes.
Well, I'll have a go, but I do need the question.
Okay, John, if you wouldn't mind repeating what you said.
Remember it. The case for the integrated care is about giving people the support that they need joined up across local councils and the NHS and other partners. It removes traditional divisions between hospitals and family doctors, between physical and mental health, and between NHS and council services. In the past, these divisions have meant too many people experience disjointed care. The organisation that has been presented to us, and it's really, other than in an interview session, this is the first time that I've met you, which I think is a real failure. The management of the ICS is perceived as being entirely remote from the front line. So the way that it's set up, it seems to me that you're going to take responsibility for all of it. And if it doesn't work, we can just say that it's the fault of the ICB, because we're not involved in any of it. I can't see how you can represent on the ICB board without representatives from the 5 local authorities which you're trying to work with.
John, thank you.
The last one was just say I'm at the moment filled with alarm and foreboding, because I think you're designing a system which is bound to fail.
So, John, thank you for the thank you for the challenge. So, obviously, we're trying to design a system that is essentially based on, legislation going through Parliament with a set of guidance around how to do that. So, you're right. I'm trying to design it with a set of parameters that come down through either statute or an anticipated statute and around the sort of the guidance. I think the important, to your point of, all the accountability somehow, gets sucked up into the sort of the ICB, is, I think, I understand the fear, but our aim, that I'm sure Catherine's taken you through, is to create, partnerships in each place-based partnerships, which actually have most of the delegated funding to them, in the same way of sort of CCGs have the delegated funding down from sort of NHS England. So the sort of UEC and the long-term conditions and a lot of the primary care would all be delegated down to that place-based partnership. Now, we do have some flex in how the place-based partnerships are arranged. So in a way, we'd like to have the dialogue in terms of how to make sure there is good, representation across, all the local authorities in Berkshire West on how that works, exactly as it does in the Unified Exec. It's a modified version of the Unified Exec, and how that place-based partnership can have be given oversight by the health and wellbeing boards that run across Berkshire West as well. So that's what we're trying to create. I understand your position on the single place-based, the single local authority partner member on the integrated care board. Again, that's the statute will tell us what we need to try and do in that particular arena. But I think the piece that's quite difficult is that it's not a representative. It's it's effectively a NED on the board is the way to think about it, that has expertise in local authorities, as well as there's another one for trusts and another one for primary care. So I understand the fears, understand that I may not be able to quell those today, but our intention is to try and build this within the statute, within the guidance, but also within each place create the partnership that can take the decisions over the majority of the funding.
But in creating the board, the statute says minimum representation. It doesn't say the maximum representation. There's absolutely nothing prevents you having 5 local authority representatives.
I think John, we're also, though, required to create a board that's effective. And I think we are concerned that if we start to increase in one partner member, then we'll also then get pressure to increase in others. And then we'll find ourselves with something that is doesn't act as a unitary board, which is also part of the statute. So it is a balancing act, I think, but I hear you and I understand the position.
Okay. Any other questions for James or Catherine, basically, that haven't been asked? And then if there aren't, what I'll try and do is, I know Catherine will give James a summary of what we've discussed, but I'll just give a brief comment basically on them. And then I've got a short statement that I'd like to read out. So any other questions first? Okay.
Like some sort of assurance that something's happening on our GP's disparity. Let me explain. Every door I knock on in various parts of the borough complain bitterly about the quality of their GPs. And they live alongside wards where the GPs are excellent. So it's not a demographic issue, it is a management issue. And you are the body which is supposed to be managing it. And this question's been lying around for 6 months now, and we don't seem to be getting any response, let alone a good response. So I need some reassurance that you are actually going to do something rather than talk to me about board structures and things which are not helpful at the moment.
So, John, as you know, we don't manage primary care. Primary care are independent contractors operating through a GMS contract, which is a national contract that is negotiated between NHS England and the BMA. So we have we support and try and support the development of primary care, but we don't manage in quite the same way. Similarly to local authorities don't manage care homes. It's a relationship that I think is slightly more nuanced. Very happy to go through complaints that you've got with any of the primary care in Woking. I'm very happy to go through those. I have tried to answer, and I know the primary care teams have tried to answer yours and Charles's issues on particular practices, where we are trying to work with them. We've given them additional funding that came down through the Winter Access Fund to try and improve them. So very happy to pick up on those separately and go through what we can try and do. And if it's helpful, also trying to see if we can get the LMC involved in how we can sort of improve, which is, as you know, the sort of union representation for primary care, which may be another way of improving. So very happy to sit down and go through the list with yourself or Charles or whoever is the most appropriate.
It is exactly the definition of disjointed care which the NHS is suggesting that will be resolved by the ICSs. So if we can't resolve a real issue which is occurring, we won't be able to resolve anything else. You might as well pack up and go home.
I think, John, not meaning to qualify John's comments, he's talking about the Wokingham Medical Centre, basically, which I know you and I have discussed before, James. I note basically discussions with Debbie and, regarding the discussions on Burma Hills the last few days, I'm being briefed on those and updated on them. So that's fine. And I note basically the recent CQC inspection, which classified the Wokingham Medical Centre as good when people can actually see a doctor there. But, I share John's view that you knock on a door in central Wokingham, this is the number one issue everybody raises, that you just can't get through to see a doctor. This is something we've discussed before, James, and we've discussed with Javed Khan, and I note your previous comments on it as well. I mean, I think in summary, I would say Catherine has tried to answer many of the questions, which has been great. She'll update you on the outstanding ones. Basically, I think for your reference, just concerns that were expressed here tonight are about Berkshire West as a place, basically, over 3 local authorities, and in particular, the practicalities of how these reforms will work in the future. And, you know, the concern that basically, to quote a conversation which has come to me today regarding Burma Hills, basically a comment that Wokingham complain about GP practices, but their GP practices are much better than Reading, but Reading never complain about anything. Now, you know, myself and the other politicians here are put here by the people of Wokingham to represent their interests, you know, not Reading's. And it was a concern basically that under this structure, there is a way basically where, you know, Wokingham issues can be dealt with and resolved rather than just being compared to other parts of Bob, which are worse. You know, we're not here to champion them. We recognise that you as the NHS are, basically, and understand that, basically. But, you know, we're just looking for a commitment that will happen. I think if there's no other comment or question, I'd like to read out a short statement which has been agreed by some of the key members of the Wellbeing Board, which just kind of formally summarises where we are. So I wanted to read out this statement to record formally the view of Wokingham Borough Council, the Health and Wellbeing Board with regards to the ICS and its formation. I've consulted key members of the Health and Wellbeing Board who deal with healthcare and opposition politicians, and all are agreed on these comments. We acknowledge that the change in NHS structure is a national directive and not up for negotiation. However, we wish to state our concerns that the new structure as proposed is flawed, and we have concerns that the voice of the residents of Wokingham by representatives of the Health and Wellbeing Board, Wokingham Borough Council and local GP practices will be diminished or silenced. Our understanding of the central government legislation, which has been confirmed tonight by Catherine, is that as much as possible in terms of healthcare should be passed to place to ensure decisions are made locally. The three local authorities in the proposed Berkshire West place have some specific different population needs. They reflect the way communities are organised and are the boundaries within which social care is delivered. And therefore, we believe place would be better defined along local authority boundaries so that concerns on any particular subject within one local authority are not compromised by the specific needs of the other. On this board, our role is to represent the best interests of Wokingham residents, and we believe they would be much better served by closer integration of health and social care within a Wokingham footprint. We have an active health and wellbeing board and integration board which works effectively. It's our belief these structures could coordinate directly with the future place representative of the ICB and should represent the views of the Wokingham community. We believe these structures should be strengthened and developed rather than eroded basically by integration across the Berkshire West footprint. We have concerns which have been expressed tonight about the lack of representation of local authority and local primary care within ICB structures, resulting in a lack of local voice in the decision-making areas. Another point which has been touched upon tonight, we note one chief executive from one of the 5 authorities will sit on the board. I note the comments about this person being a NED, which you both made basically, but you know they will be in a position where they'll be asked to give advice or opinions on things happening in the area. And we have cannot understand how, for example, the leader of Oxfordshire Council can have any knowledge of Wokingham, West Berkshire, Buckinghamshire issues. We fear this will lead to decisions being made with no accountability and minimal local voice, which in the end results in poor outcomes for our residents. We note the intended recruitment of a place director for Berkshire West. Our concern is they will have a Berkshire West view and will not understand the requirement to allow innovation within the Wokingham footprint to support our population with their needs, which may be and will be different from other parts of Berkshire West. This candidate should therefore be proactive in understanding and work the needs of the population of the Wokingham locality and working with us to actually push them forwards. We regret that we have to make this kind of statement as we wish to have a constructive relationship and work in partnership with the NHS. However, we do believe the current approach is flawed. Wokingham Health and Social Care have always tried to work collaboratively and successfully with local NHS providers and Wokingham Borough Council. The COVID pandemic accelerated some of this joined-up approach, which worked well for our residents, and we do not wish to see this eroded with the lack of a strong Wokingham voice in the ICB. We wish to record that it is our view that Wokingham should have its own place-based partnership in the structure. Our motivation is not to cause unnecessary arguments, basically, or conflict, but simply that we seek the best healthcare possible for our residents. And we'd ask that the ICS and the CCG listen to our comments, respond to our concerns, and adopt the plan to reflect our wishes. And we'd be happy to engage in constructive discussions to try and move this forwards. Thank you. Unless there are any other comments, questions, or discussions, I think, and I can see no hands up, I'd like to thank everybody for attending tonight, particularly James and Catherine. And I'm sorry, basically, this meeting has some of the tone of this meeting on a personal level. We do wish to work constructively with you, basically, and I'll say good night to everybody. Thank you.